Okay, let's look at Chapter 2, Biological Foundations. In this chapter, we're going to be talking about heredity, fertilization, prenatal development, and birth. So I guess we begin with a discussion of genetics and genetic inheritance. So first, let's get some terms together. The genotype is the actual presence of DNA on the chromosomes in the form of genes. And this is what I was talking about before. The genotype is the sum of information passed on from 7 generations. The genes that are the most effective for survival get passed on, and we'll talk about that in a minute. That's the evolutionary process. So the genotype results in the phenotype. The phenotype is the actual observable traits or some measurable traits or predispositions that are the result of the expression of genes. And then, as we talked about before, epigenetics is the study of how the combination of gene expressions and influences from the environment determine ultimately what traits will emerge. As you probably learned in your biology classes, chromosomes are double helix structures on which genes are organized in pairs called alleles. This was discovered by Watson and Crick, for which they won the Nobel Prize. They actually built a big model of a chromosome in their lab and determined that the only thing that could explain the traits in the chromosomes, how they are structured, was to finally organize them in a spiraling pattern. At each allele, which are connected by base pairs on the 2 chromosomal strands, each gene comes from one of the parents. So you have the mom gene and the dad gene bonded together by base pairs at each location or each allele on the chromosome. And this is all designed to sort of zip and unzip as you go through mitosis and cell division. So this is what brings about the manifestation of ancestry. And so this is actually natural selection leading to evolution at the cellular level, because it is the recombination of ancestry, genetic ancestry from the mother's side of the family and ancestry from the father's side of the family with genes that are the most beneficial for whoever survived to procreate on either side of the family, passing on that to the newest offspring. So you can see that the chromosomes at one stage are bound together by a centromere, and then they go through regular cell division. So the question is, when you have 2 genes bound together by base pairs and an allele on a chromosomal strand, which one expresses? This is where you see a process that is duplicated in other parts of the body, actually, in other systems, and that's called the opponent process. What happens is that one of the genes will have the capacity to turn off the expression of the other gene, either turn it off completely or partially turn it off. And being able to turn off the other gene, that makes that gene the one that has the ability to turn off the other gene, the dominant gene. The gene that gets turned off by its partner there is actually called the recessive gene. So the dominant gene expresses because it has turned off the recessive gene. And these opponent processes, like I said, are in different parts of the body. The ovaries actually have a similar opponent process, which is what generally results in an ovary ovulating every 28 to 30 day cycle. And then the one that ovulated 1 month turns off the other one that month, and then the next month the other one gets turned off, and you have them alternate. So ovary A ovulates, by turning off ovary B, and then the next month ovary B turns off ovary A, the previous ovulation, and it ovulates. Why? Why does that happen that way? Well, it turns out that that's actually really beneficial for survival, and it tells us something. It tells us that ovulation is critically important for species survival. So what you have there is a process that allows for the loss of an ovary, because if an ovary gets lost due to disease or injury, or the mom was just born without it, then what gets lost is actually the ability to turn off the other ovary. So what happens is that the opponent process is lost. If the opponent process is lost, there is no turning off of the remaining ovary, and it'll ovulate every month. So that's kind of how opponent processes work. So understanding how genetics works and chromosomes work gives us some clinical abilities, some diagnostic abilities. So one of those is to actually be able to form a chart that has all of the chromosomes. Humans have 23 pairs of chromosomes for a total of 46. And those line up, one from mom, one from dad, at each site on a chart. The chart's called a karyotype. So what we can do is actually there's a procedure by which some chromosomes can be drawn in amniotic fluid through the belly wall with a needle. That's called amniocentesis, and you can get chromosomes out into a microscopic field. They can be stained and photographed using something like a Photoshop program. They can make a digital photograph. And then they can organize those chromosomal strands into pairs and examine them to see if all of the parts are there, if you have any legs missing, and to see if they're still joined at the centromere. And you can also tell on the 23rd pair whether you have an XX or an XY chromosome. Because if you have an XY chromosome, you have a male. If you don't have an XY chromosome, you have a female, because you'll have an XX chromosome. So the presence of the Y chromosome is what differentiates the embryo to male, or the fetus to male. Let's look at differentiation of the urogenital tract in males. First of all, we have an XX or XY determinant of male or female. So really biologically, the way it works is if you have a Y, everybody has an X chromosome. Females have 2 X chromosomes. The Y chromosome is what differentiates. So males have a Y chromosome, females do not. And this is what causes differentiation. So the Y chromosome sends a signal that causes the undifferentiated gonads during organogenesis to differentiate into what are going to be testes, and they're going to secrete testosterone. So testosterone is the differentiating hormone. So what we can say is that males are differentiated, females are not. If you just leave it alone, it grows as a female. If you introduce a Y chromosome, the Y chromosome differentiates the gonads secrete testosterone, then you get differentiation into a male. I'm not going to ask you all the details of this on the exam, but it's just interesting how it works out, because you really have undifferentiated ducts at first, Wolffian ducts and Müllerian ducts, in the earliest part of the urogenital tract, where the gonads are and what are going to be the ureters and all that. The Wolffian ducts, if there is a Y chromosome and testosterone, develop. And then as a result, the Müllerian ducts will recede. And so what happens as a result of the presence of testosterone is that the urogenital tract externalizes. So every tissue that you can see in a female urogenital tract and genitalia has an analogous tissue in the male urogenital tract and the male genitalia. So they all have the same structures. They're just developed differently in proportion. And so you can see here how differentiation works. So, but the main takeaway is that if you don't have the Y chromosome, it's just going to grow as a female. Now later on, this actually becomes important because there's two X chromosomes in females. They have double coverage for traits on the X chromosome, and there are certain things that are on the X chromosome that are important traits, like blood clotting is on the X chromosome. And so females, the absence of that gene, the genetic capability of blood clotting, is called hemophilia. And females can be carriers of hemophilia because they can inherit it on one of the X chromosomes, but they have another X chromosome. So that, for example, if a fetus inherits a conceptus inherits the gene for hemophilia, which would be a non-functional clotting gene, then it's going to be on the X chromosome, but they're going to get another X chromosome from their other parent, and that's going to cover it because it's a recessive trait, and so that's called an X-linked recessive trait. And now, in males, you have an XY chromosome, so that trait, if it's recessive and on the X chromosome, is going to express because there's no coverage on the Y chromosome. So that's why males are prone to X-linked recessive expressions like hemophilia. Another one's color blindness. Females don't tend to get they don't tend to be born with color blindness. So dichromaps, which is the most common form of color blindness, where you have one missing conal structure. In other words, some hues of light you cannot see or differentiate. You're not going to know that until you take a test later on, or somebody notices your socks don't match. But males tend to express that. So the probability of having a female hemophiliac is really low, and the probability of having a female with color blindness is really low because they would have to inherit the trait from their father by getting an X chromosome, and from their mother, who would actually be a carrier of that trait. So you'd have to have a colorblind father with a colorblind carrier mom, or a hemophiliac father with a hemophiliac carrier mom. So the probability of that is actually really low. So here's an example of a karyotype indicating a syndrome called Down syndrome, or trisomy 21. It's called trisomy 21 because you have 3 21st chromosomes. This is one of the most common chromosomal abnormalities, mainly because it's survivable. There are people that born with trisomy 21, and the survival rate of individuals born with trisomy 21 is much higher than it was historically, mainly because of medical care conditions they can treat that are the result of trisomy 21. So what you'll see here is if you look at the 21st pair, you have an extra chromosome, and in chromosome world, too many is bad. You want just the right number. So this is a female XX with trisomy 21, and you can see that she has some pretty typical features that you see in Down syndrome kids. She has extra folds of tissue over her eyes. They're short in stature. They have short digits. They're prone to learning disabilities, intellectual disabilities. They're also prone to cardiac arrhythmias cardiac abnormalities, which now can be actually treated with surgery with about a 90+% success rate. And they're prone to some other problems like later on, like metabolic problems, managing their weight. They have a significantly shorter lifespan than non-trisomy 21 people do. Here's another example of a chromosomal abnormality, Patau syndrome, which is trisomy 13. The abnormalities are generally much more dramatic with trisomy 13. You have kidney, heart, CNS malformations. That's brain malformations, which results in brain disabilities. They tend to be out of proportion, the underdeveloped cranium. About 80% of them don't live past the first year. And cleft palate, dysplastic or malformed ears, and polydactyly are all common in babies with trisomy 13. In the field of behavioral genetics, we look at how psychological predispositions, abilities, and all of the things under the heading of psychological function are inherited, like what aspects of them are inherited. So these are generally not linear kinds of inheritance. They're polygenetic and, of course, heavily influenced by environment. But they tend to involve many interacting genetic expressions. And so that's why early exposure to certain conditions can have a pretty dramatic effect on the manifestation of psychological predispositions, like kind of a little bit like what we were talking about before. If you had a real strong predisposition to be very athletic or be very talented in any kind of field like music or art, or to be exceptional in sciences, or some combination of those things, then whatever you're exposed to when the brain is in the highest state of neuroplasticity, then that is going to have a more dramatic effect on what that predisposition is. So predispositions can be never turned on if there's a environment that's deprived, where there's a lot of deprivation in any of those opportunities. You can have a failure of predisposition, and you'd never know it was there. So also, when I say it's not a linear process, so you'll hear sometimes people say, well, that person, they had the gene for alcoholism, or, they had the gene for, some particular problem. And in the psychological predispositions, there's really no evidence that there's a gene for these things specifically. So there's no gene for alcoholism. The truth is that a person that develops a problem with alcohol, can keep in mind that alcohol consumption is not a natural part of nature. It'd be really hard to find enough alcohol in nature to even become intoxicated. I mean, it just doesn't exist in large amounts. It's not available to humans much in nature, which is true for a lot of psychoactive substances. Now, they're just not that common in nature, although some are more common in nature. But generally, we don't have sort of a natural genetic predisposition for alcoholism, but we do have a range of what would make somebody susceptible. It's more an apologenetic trait. It involves some aspects of personality, and but it also involves just how they tolerate alcohol. For example, somebody that drinks alcohol for the first time and they get a very intense euphoria from it, especially if they're not that happy to begin with, and they get a very intense euphoria from the alcohol, then they would be much more prone to become an abuser of alcohol, although that's no guarantee, but they would be much more prone to that. If a person is more prone to be somewhat impulsive or reactive to environmental stimuli, or bored easily, then that component paired with a strong euphoric reaction to alcohol may make them more vulnerable to becoming dependent on alcohol or some other drug. You could say the same thing for opioids or cocaine or any of those drugs. So they all act on dopamine receptors in the brain. However, if you did not have that, if you drank and all you got was a little bit sleepy and had only mild euphoria, then you would be at very low risk for ever developing a dependency on alcohol. So that's just one of those biological predispositions, those genetic biological components that is combined with other genetic biological components that sets a person up to have that trait, which would be the susceptibility to alcohol. Same thing's true with intelligence and a variety of other traits that people have, including personality. In fact, you can see genetic predispositions for personality very, very early when you look at how sensitive a person is in reacting to environmental stimuli. So, for example, some babies, they're born, somewhat irritable in temperament, and they are hard to calm and intense when they cry, and they just seem to be irritable most of the time. That may be a predisposition for some aspects of personality that continue to develop in that direction, although there's no guarantee that when they turn 25 that they're going to be an irritable adult. It's just an early trait that tends to be more a sign of their inheritance. But we do see trends, like if a person has two parents or a long lineage of people in their family, all of which had problems with alcohol. You see, I've had patients where had multiple family members in their past that had died of cirrhosis of the liver or pancreatitis or just alcoholism, and they themselves found that at an early age they were exposed to alcohol. Now, part of that's family and culture and the availability of alcohol around them when they're little. There are studies that show that the earlier you're exposed to alcohol, especially in early childhood, it's a setup for being much more likely to develop a abuse problem or dependence later on, as long as that predisposition is there. And so that's kind of how these polygenetic traits work. They're very complex. The more we learn about genetics, the more we learn that it's not, such a determinate process. It's actually much more of an interactive process, and genes, the way they express, may respond much more to environmental variables than we previously knew. Let's look at twinning and how twins are formed. There's actually two categories of twins that are going to become really relevant for research later on, because we can use twin studies in research, and a lot of our literature in looking at the nature versus nurture debate and what factors come from biology and which ones are from society or social cultural variables comes from comparing monozygotic and dizygotic twins. So let's look at what the differences are. There's only one kind of dizygotic twinning, and that's actually just two babies being born at the same time. There's two ovulations, both fertilized, and they implant as two separate zygotes or blastocysts by that point, and form as two siblings with separate amnia. So they're really no more similar than any two siblings. They can be male and female. They can look exactly alike, but they don't necessarily. But they don't have to. So so dizygotic twins do not share the same exact DNA. They're going to be different. Monozygotic twinning happens with only one fertilization, one ovulation, one fertilization. It forms a zygote. But then the zygote can split at different times through the process leading up to and after the first week of implantation. So either the ball of cells called the morula can divide right away in the very first cell division in the zygote. In that case, you have two identical morula that implant as blastocysts, and they're going to have exactly the same DNA. And they're also, but they will have their own separate amnia. So the amniotic sac is the little sac that the baby grows in. So the chorions are independent and the amnia are independent, but the babies are identical. The other way that can happen is you can have a morula that hatches into a blastocyst, and then the blastocyst can divide at that point, at which point they'll share a chorion, but they'll have separate amnia. Also identical twins. Or the splitting can come late, after about a week after implantation, and the blastocyst can actually split into two identical embryos, and in that case, they actually have the same chorion and the same amnion, and share the space in the amnion. Now, the only thing that's relevant for our discussion here is monozygotic versus dizygotic twins. It's just really interesting in the way that monozygotic twinning happens, and how, when the split occurs, which part of cell division the split occurs, determines how they're going to present in the uterus during gestation. So, what is twinning? How's twinning relevant for research? Because this is really handy when you're doing research. Because remember the nature versus nurture debate. This is one way of really sorting out what aspects of traits and development are nature and which ones are nurture. So monozygotic twins are genetically identical. So what you're doing there is, if you compare monozygotic twins raised together with monozygotic twins raised that were separated at birth, you're holding biology constant and manipulating differences in environment. So any difference in those children, when you compare them on any measure, like, you know, intelligence, personality, medical risks, anything like that, what you're really looking at is the effect of the environment, because they share the same biology. You also have dizygotic twins, and in studies of dizygotic twins, you can look at you can compare dizygotic twins with monozygotic twins raised together. So you can have monozygotic twins raised together and compare with dizygotic twins raised together. And at that point, the environment's held constant because they both have the same parental and social environment. And but they vary genetically, so like biologically. So monozygotic twins and dizygotic twins don't have the same biology. So how much is their similarity or dissimilarity the result of the differences in their biology? Because when they're raised together, you're holding environment constant and manipulating biology. So this gives you the ability to, do multivariate studies to determine exactly how much the environment affects development and how much does biology stabilize development. There have been some remarkable studies where they found that biology has pretty strong effects on similarity, where they looked at monozygotic twins raised separately and found remarkable similarities in the two in how they turned out as adults, even though they had significantly different environments. So let's look at twin studies, which we've talked about. We're comparing the role of biology versus socialization, and that's the question here. So let's examine one remarkable finding in a study of twins separated at birth. And this was the case of the two gems. This was a study done by Thomas Bouchard at the University of Minnesota, where he interviewed a pair of twins who had been separated at birth and adopted into adoptive families, who then gave them a name and raised them, and they didn't find out about each other until they were 39 years old, at which point Dr. Bouchard had contact with these twins and did some personality testing, brainwave testing, and took their medical histories and their psychosocial histories. And he found some incredible similarities between the two gems. As you can see here, when we compare the histories of the two gems and their characteristics, they both had a brother named Larry, both had a dog named Toy, both enjoyed math and word woodworking, both expressed a strong dislike of reading and spelling, both married women named Linda, in marriages that ended in divorce, both remarried women named Betty, both had sons that they named James Allen, both were chain smokers and suffered from migraine headaches. They both drove a Chevrolet. One worked as a security guard and the other worked as a deputy sheriff. Now, these are phenomenal similarities. In his testing, Dr. Bouchard found that they both even drew the same picture when they were asked to draw a picture, had almost identical personality traits, which you would perhaps expect. They grew up only 40 miles apart from each other in similar environments, and they had the same DNA, being identical twins. So this is one of those really remarkable examples of the role of biology. Let's look at the most significant difference between males and females biologically, and that would be in their gametes. Gametes in females are the oocytes, gametes in males are the spermatocytes. Females have a fixed number of gametes at birth that develop during organogenesis and gestation and maturation of the ovaries. Keep in mind that the urogenital tract and the ovaries in females are undifferentiated, so this is without the role of the Y chromosome. What you have is basically immature oocytes that mature through a process with influence from follicle-stimulating hormone. Follicle-stimulating hormone and estrogen are responsible for the ovulation process in females, along with luteinizing hormones, which we'll talk about. But the follicle matures into an oocyte. And then luteinizing hormone causes the oocyte to be expelled through the ovarian wall into the peritoneal cavity, where it's picked up by the infundibulum. So you have a fixed number of cells. They're going to ovulate approximately every 28 to 30 days through the reproductive years, and this is the contributor for 23 chromosomes, which are going to be available for fertilization, and this is the host cell. So as a result, females are the host for the pregnancy, and they provide the host cell, which is the oocyte. So the spermatocyte is the donor cell. It donates 23 chromosomes at fertilization. Which brings us to the role of the spermatocyte. So spermatocytes do not develop until puberty. So oocytes begin to be matured one at a time, sometimes two, every menstrual cycle or ovulation cycle. Spermatocytes don't really develop until puberty, when they're expelled with each ejaculation in very large numbers. So spermatogenesis actually doesn't occur until puberty, whereas oogenesis happens in gestation. Significant difference in males and females. Not only that, but females only ovulate during their reproductive years, from puberty until they go through climacteric, perimenopause, and menopause. Spermatocytes, on the other hand, are produced and ejaculated all the way from puberty into late life, even though numbers decline and the quality of the spermatocytes decline as you get past midlife. Spermatocytes are much simpler than oocytes. So they have a nucleus and acrosome, a mitochondria, which is the little motor that operates the flagellum. And they actually, the flagellum doesn't really wave like a tail, like it was previously thought. Actually, the way the sperm cell works is when it's released into the vaginal canal, it corkscrews its way up the vaginal canal. So it operates more like a boat prop than a wagging tail like a fish. And so the sperm cells rotate and move up the vaginal canal for contact with the oocyte. And fertilization has 23 chromosomes. It's the haploid number, combines with the 23 chromosomes in the oocyte that gives you the diploid number, and that's the zygote and fertilization. The zygote is a one-celled organism, and the period of the zygote is the time period between fertilization, migration through the fallopian tube, and implantation in the uterine lining. The uterine lining is prepared through secretion of progesterone. So luteinizing hormone causes the oocyte to be released into the peritoneal cavity. It's picked up by the fimbriae, which are these projections with a sticky kind of mucus on them. And then it progresses up the infundibulum until it gets to this area called the ampulla, where it's most likely to be fertilized. That's the bend in the fallopian tube there. And then it progresses after it's been fertilized, if it does fertilize, down into the uterine lining that's been prepared by progesterone. It's at that point that really the zygote is going to be through the morula stage, which is a ball of undifferentiated cells, until it differentiates until the cell layers. And about that time, it's going to be entering the embryonic stage as it implants in the uterine lining. And this just shows you the period of the zygote in stages. Don't memorize all of this. We're not going to have questions on the test with this kind of detail, but it's just interesting to see how fertilization takes place, and then you have the zygote, and then you have the first cell division, and then multiple cell divisions. Those are all undifferentiated cells. They're just balls of the same cells. So the morula is just a ball of cells. Then it hollows out into a blastocyst, and that's so that nutrients can get to the interior cells. And then about the time it starts to implant in the uterine lining, the blastocyst will start to differentiate into cell layers, and those are going to become the different tissues. It's the differentiation of those cell layers that are going to begin to form all of the tissues that are going to make up the different systems. So the interior layer is called endoderm. That's going to be digestive system, liver, pancreas, lungs. And if you look at the tissue in those structures, they tend to be squamous epithelia. They're real smooth, kind of mucousy tissues. Those are endoderm tissues, many of them. Then the mesoderm layer is the middle layer, and that's going to be circulatory system, lung, skeletal system, and the muscular system. And then the ectoderm layer is all the outer tissues, the hair, skin, nails, and the nervous system. Again, don't memorize all of the different details in the endoderm, mesoderm, ectoderm. The main thing that's important here is that this is the initiation of the embryonic stage, and this lays the foundation for organogenesis. So one of the test questions is, what is the most important thing that happens during the embryonic stage? And the answer to that is differentiation of the cell layers and organogenesis. So organogenesis is the formation of all the organ systems. And so the foundation for the organ systems, the fundamentals, are laid down throughout this 8-week period, from 3rd week to 8 weeks. And this is also going to require, right after implantation and organogenesis, the support structures are going to develop, and that's going to be the placenta, the amnion, and the umbilicus. The amnion is the sac that the baby grows in. The placenta is a disc of vessels that allow for oxygen nutrient exchange between mom's bloodstream and babies. Also provides a little barrier there against some bacteria and viruses. And then the umbilicus is the connection between the two. So there's an umbilical vein and umbilical arteries that provide circulation. So the baby's completely dependent on mom's serum oxygen. Her liver and kidneys take care of waste products. CO2 is transported back into mom's system to be expelled by her lungs. So the baby is basically like a little Navy diver in there with an umbilical going to mom's system. What's important about this early stage, this differentiation of the cell layers and organogenesis throughout the embryonic period, as you can see, for our purposes especially, you're looking at neurons and brain development in the ectoderm layer very early on. And then other real critical structures for survival that are being formed at this point. And that's why anything that disrupts development, malnutrition, exposure to toxins, exposure to radiation, birth trauma, or any kind of traumatic problems in mom's system that wind up being a problem for the baby's system, these can have profound effects because you're dealing with a very few cells that through cell division and growth are going to later become billions and billions of cells, and so any abnormality in these very early cells can be dramatic abnormalities later on and threaten the normal development or completion of development. So if you have big disruptions at this level, either it's not a great genetic match or there's exposure to certain toxins or malnutrition, the probability of a spontaneous abortion or miscarriage goes up significantly. There's a couple of terms we need to look at here. One of them is the cephalocaudal trend, and the other is the proximal distal trend. So cephalocaudal means head to tail. It's an embryological term, actually, because the embryo develops from the top down, from what's going to be the cranium all the way down to the lower extremities. The cranium and that area developing first. There's actually a really interesting process that happens in early embryogenesis where contractions that are going to be the coronary system or the heart begin in the cephalic end of the embryo, and then it kind of wraps around to form and folds over to form the mediastinum and the posterior aspect of what's going to be the spinal column. So, so the cephalocaudal trend is the reason that you can see that babies form from the head down, and the most the upper structures are the ones they gain control over first, and they have the most fine development as opposed to the lower structures that take a while. In the proximal distal trend, you're looking at development from the midline out. So what you see is that control and development of the core structures in the middle of the body, the central nervous system, the muscles closer to the spine, they get control over those before they get control over the fine muscles in the extremities. So this gives us some control over, or some understanding of why we see things develop the way they do. In the proximal distal development trend, you basically see large muscle control first. That's gross muscle control, like, for example, arm movement, voluntary arm movement close to the core of the body, and movement of large muscles in the back, like the latissimus dorsi and the rhomboids and the trapezius muscles. Those big muscles in the middle line of the body are the ones that they get control of first. Even look at their grasp. Babies tend to grasp with their palm and wrap their fingers around it when they do gain some voluntary control over grasping. Eventually, they're going to get what's called a pincer grasp, which is where they can use fingers to pick up things. And so you see progress develop from gross to fine, proximal to distal. And you see it even in their motor, their movement. Like, for example, babies tend to pull themselves along with their upper body or roll over by arching their back and moving their head before they have other kinds of voluntary movement. They tend to stand by pulling themselves up with their hands and push up with large muscles in the upper part of their legs before they can walk. Walking actually requires fine motor control in the muscles of the ankles, proprioceptors in the ankles, the plantar part of the foot, and their toes. That's where their ability to balance and walk all comes from those real fine muscles and motor control in their extremities. So you had the germinal stage, which goes up to about week 3, and then you have the embryonic stage, which goes up to about week 8, and then 9 through the remainder of gestation, which is going to be about 38 weeks, is the fetal period. So by the time you're in the fetal period, most of the fundamentals are laid down. So the fundamentals in the organ systems, although the details aren't there yet, the fundamentals are pretty much laid down at that point. So you do have some, you start to see development of convolutions in the neocortex. That's the kind of folds and lumpy, bumpy part of the brain. Myelination of certain critical pathways for survival, like the brain stem, the medulla, where you see breathing, heart rate, vasodilation and constriction, reflexive motor responses, and there's no voluntary motor control at that point, and sensory responses. Your book refers to these as perceptions, but babies don't have perceptions. Perceptions are organizations of sensations. Babies do have sensations, though, and so their sensations and the motor responses to their sensations are in the reflex arcs, and they're not the motor cortex isn't functional in a newborn baby. Development and myelination of the brain is what causes voluntary motor control. And then eventually taste, smell, vision, hearing, all begin to organize as perceptions. So you're not going to see perceptions until all the sensory systems are in and the brain's developed enough to where the baby starts to form impressions of the world. You know, they start to interpret sensory information. Also, in the fetus, the most important thing that happens in the fetal stage is towards the end of the fetal stage. The last few weeks before they're born, they've got to be prepared for birth. So you get some myelination of the brain stem that's going to be needed for breathing and maintenance of blood pressure. Vernix, which is a kind of a lotion mucus that forms on the skin that protects the skin from chafing due to amniotic fluid and also aids in transition down the birth canal. Pulmonary surfactant, which is the most important thing that happens in the latter part of the fetal period, which is deposits of mucus on the alveoli and the lungs. This allows the alveoli to form a pressure differential and inflate whenever air begins to infiltrate the lungs at their first breath. If they don't have enough surfactant, then the alveoli will not inflate, and you can get what's called a respiratory distress syndrome at birth. And that's actually fairly common in kids that are born early or underdeveloped when they're born. And that can trigger a respiratory distress protocol, which involves 100% oxygen, some glucose, usually by mouth, to give them energy, and then monitoring of their pulse oxygen. If their pulse oxygen doesn't come up, there's actually a treatment they can give them that's an artificial pulmonary surfactant that was developed several years ago. And it's this invention of pulmonary surfactant that really affected the age of viability. Age of viability was about 28 weeks. That was about as early as a baby could be born before the invention of pulmonary surfactant, artificial surfactant, they weren't expected to really survive if they were born any earlier than about 28 weeks. But what happened was, with the invention of pulmonary surfactant, you could get babies surviving at 22 weeks, which is a significant improvement in survivability of babies. So when they're born with a respiratory distress syndrome, and because they're born so early, then they can treat them with a pulmonary surfactant and respiratory distress protocol and improve their chance of survival. They can remain, they're born as neonates, they just remain in the neonatal period much longer and complete their gestation outside the uterus. So once they're born. But some interesting thing happened as a result, and that is that you could see these really tiny babies, sub 1 pound babies born. As you can see here, the size of a person's hand. I've seen these in the neonatal unit over at John Peter Smith Hospital, and they had to actually invent some medical appliances that they could use with these super small babies, like airways and catheters and IV needles and things like that they could do with these super small babies, and the techniques required to take care of them had to be developed after they invented pulmonary surfactant. Now we can look at some threats to a healthy baby, and these are referred to primarily as teratogens. Teratogen is, the way you're going to see it on the test, is it's any agent that can adversely affect the fetus during development. So we usually think of teratogens as drugs, but they're not necessarily always drugs. Some remarkable ones, the most common ones these days are alcohol, which can result in either fetal alcohol spectrum disorder or fetal alcohol disorder. We'll talk about that a little bit later. Opioid exposure, moms maybe before they know they're pregnant, taking or addicted to opioid drugs, stimulants like methamphetamine or real high doses of caffeine and other kinds of stimulants. And then some antibiotics like tetracycline, given for urinary tract infections, can cause bone malformations in the developing fetus. So tetracycline is red labeled by the pharmacist. It's not a drug that can be prescribed for babies. And there's many others. It's interesting the way the pharmacologists deal with, and the FDA deals with, drugs and the risk of pregnancy. That is, prescription drugs and the risk of pregnancy. And that is that the default is if there's no evidence that the drug has been proven safe to be used during pregnancy, it's either going to get a warning label or a prohibition, a red label. So, for example, if they have evidence that a drug's harmful, that it's teratogenic, then they're going to put a red label on there, and you can't prescribe that for somebody who may be pregnant. They'll have to get a pregnancy test and make sure they're not pregnant before they can take it if they're a female in reproductive years. If the drug has not been found to be a teratogen, but it has also not been found to be safe during pregnancy, it gets a warning label. And then at that point, it's up to the physician to make a determination as to whether it's necessary for that patient to take that medicine or to screen them to see if they're pregnant before they can make that decision. They may already know they're pregnant and they need to prescribe it anyway, but it'll get a warning label. And then there's drugs that have been found to be safe, like Tylenol and many others. Some antibiotics, some psychiatric medicines have been found to be safe for women that are pregnant. They have no evidence that they're teratogenic in any way. Other forms of teratogens can be things like teratogenic effects can be malnutrition, which is significant. We're a pretty much fed society. We don't have the greatest food for every income bracket, but we don't have a significant starving population in the United States because we have a social safety net, although many believe that it could definitely be improved. But in some parts of the world, malnutrition is a significant problem, and it's the biggest problem for babies in gestation. I remember talking to, when I was in the Army and deployed, and I was talking to a aid worker who was actually a nurse who was there as a relief worker overseas, and had been heavily involved in the Blue Cross and UNICEF and Doctors Without Borders. And she was a strategist, a malnutrition strategist for arranging aid. And she said that what they do is they set up a hierarchy of priorities. The first priority is fresh water, get the pregnant moms fed, get them nutrients, get them hydrated, and get any kind of infections that they have treated. So that was the very first priority in triage. The second was newborn babies and their moms. Get the moms prepared to be able to breastfeed the babies, because when the babies aren't breastfed and they're trying to give them, trying to feed them with local water supplies that aren't good and things like that, they try to get the babies on a breastfed only diet, because breast milk is the mom's body makes the breast milk safer. So they'd get the mom fixed up and get her able to breastfeed. And then the next one was newborns and children, young children that are under 5 years old, because they're in the myelination stage and they need to be fed so that they can develop those fundamental structures before they reach the end of the critical period at age 5. So what's interesting about that is that if a baby's in pretty bad condition before in infancy or toddlerhood, sometimes a toddler can actually look like an infant. They've just got so much growth deprivation but when they get fed, they tend to go into recovery growth. They'll actually catch up. And that happens with their skills too. They generally catch up. So they'll be up with their peers if they're fed soon enough. So that's a real issue with either malnutrition can be categorized as inappropriate or unhealthy food, or a lack of calories. The other risk in malnutrition is inadequate folic acid in the diet, which can raise the risk for neurotube defects like spina bifida and encephaly. And so in the U.S., what we do is we have folic acid in the prenatal vitamins. Prenatal vitamins are the only vitamins that are regulated by the FDA. So the FDA tests the prenatal vitamins, which are now not by prescription. You can get them off the shelf. But the FDA regulates those vitamins. They have to have the quantities in them, including folic acid, that's on the label, unlike other vitamins that are not regulated by the FDA. Another issue with during gestation can be maternal stress. When mothers are exposed to high levels of stress that result in high levels of adrenaline in their system, it can have the same effect on the developing fetus as any other stimulant would. So that can result in preterm, that's underdeveloped, or small for date infants, that is, ones that are born too early. It also can result in preschoolers and infants that are prone to be in irritability, and have an attention deficits have been found to be tied to maternal stress. So what you have is just a consistent exposure to adrenaline in a mother's system, and it has an effect on the baby's system. So one of the more serious teratogens that's actually pretty common is fetal alcohol syndrome, or fetal alcohol spectrum disorder. The reason that it's common is because it's easy for but partially because of the addictive nature of alcohol, but also because it's easy for someone who's even not addicted to alcohol, a female, young female especially, to wind up drinking when they don't know they're pregnant, because they may not realize you can go all the way up into the embryonic stage and not know you're pregnant. And if they were to drink a lot on a couple of occasions in very early pregnancy, then they could wind up exposing the fetus to high doses of alcohol. It's interesting that alcohol in the fetal space actually builds up higher in the baby's bloodstream than it is in the mom's. And that's because of the sort of pressure differential and circulatory differences in the mom and the fetus. When mom drinks, she gets a dose of alcohol in her bloodstream, and then her liver produces alcohol dehydrogenase to metabolize the alcohol into acetaldehyde. It's actually the acetaldehyde that's toxic. That's what gives you a hangover. So acetaldehyde builds up in the baby's bloodstream because of the alcohol dehydrogenase is secreted from mom's liver. And when the acetaldehyde builds up in the baby's bloodstream, that is tissue toxic to the baby. The acetaldehyde in mom's bloodstream gets metabolized away by the liver. But it takes a while for the acetaldehyde in the baby's bloodstream to be metabolized. And so it actually builds up a little higher than that in the mom's bloodstream. And so it's thought that babies actually have a little higher dose of both alcohol and acetaldehyde than the mom does, which is why it doesn't take a lot of alcohol to see some possible effects in the baby. There's no guarantee there will be effects, but some possible effects in the baby. Now, if you can see the actual facial features or you have dramatic effects from the alcohol exposure, that's fetal alcohol syndrome in the severe range. And that's when, you can see here in this little girl's face, she has short palpebral fissure lengths, smooth upper and low definition in her upper lip, and a small upper lip, wide set eyes. And that's pretty typical of somebody with fetal alcohol syndrome. She may, in addition, have some of the other neuropsychological or neurosigns like low IQ, learning disabilities, or language delays. It's possible, though, in some cases where you have mild expressions, you don't see any facial features or physical changes. They don't have the coronary malformations in the more severe cases. They don't have those in the mild cases. In the mild cases, though, it may not be discovered until the preschool years or in toddlerhood when they're not developing language at the normal rate, or when they get into the preschool years and they begin to have show difficulties with both language and mastering arithmetic tasks and things like that. Sometimes their executive function's not as good as their peers, so they're prone to throwing fits or having difficulty with control over impulses. And so those are called the mild fetal alcohol spectrum disorder, and those are harder to differentiate. It's harder to form an absolute conclusion that this is the result of alcohol exposure. Whereas in the more severe cases, it's much easier to make the diagnosis. Here we can see an abnormality that's the result of an abnormal chromosomal karyotype. So when they make a prenatal diagnosis, one of the most common ones is Down syndrome. And Down syndrome is called Trisomy 21 because you have an extra chromosome on the 21st pair. And it's usually detected first in a low-risk pregnancy by an alpha-fetal protein test that gives you the possibility of chromosomal or genetic abnormalities by the alpha-fetal protein levels being a little too high or a little too low. That's not diagnostic. It's just a red flag to do an ultrasound. and amniocentesis. And so amniocentesis is a insertion of a needle through the belly wall and drawing out of amniotic fluid so that you can take the chromosomes under a microscope, stain them, and then arrange them in these pairs like we talked about before. When someone is diagnosed with a possible chromosomal abnormality, or in any high-risk pregnancy like multiples, or the health of the mom can be tagged as a high-risk pregnancy like gestational diabetes, or a mom that has type 1 or type 2 diabetes, or a heart problem, anything that could place the fetus at risk, they'll get a referral to perinatology. So perinatologist is a sort of a hybrid pediatrician, gynecologist, obstetrician. So what they do is they take care of babies during gestation and their moms. And so this is kind of a relatively new branch of medicine, and it's pretty much an automatic referral if you have a high-risk pregnancy. Now, one of the biggest risks in the birthing process is the prolonged cutoff of the baby's oxygen supply called hypoxia. Nowadays, there's fetal monitoring of the pulse oxygen level of the mom and the baby, and a monitoring of contractions and mother's heart rate and respiratory rate. And what they can do if the baby winds up in distress, which can be signaled by Marconium staining, which is when the baby's bowel empties into the amniotic fluid, or if the mom comes into some kind of a crisis, she has a seizure, or she starts to have what's called bradycardia, where the heart, her heart develops a really slow rhythm. She starts to have circulation problems, or her blood pressure drops, or she gets signs of toxic shock or high blood pressure, then they can elect to do a cesarean. So a cesarean section is just a excision through the belly wall and removal of the baby in a transverse incision there. Cesareans have been responsible for reducing the birth defects, where without a cesarean, a baby could be born with brain damage or nervous system damage as a result of prolonged hypoxia. And cesareans were actually done all the way back to Roman times. In fact, that's how it got the term cesarean. There was actually a rumor that Caesar had been born by excision. At that time, though, they didn't do cesareans on live moms. The mom, if she died during childbirth, especially even, a baby that was real important, they would actually do an excision and save the baby after the mom died in childbirth. So babies in Rome weren't born to live moms through cesarean. But it got called a cesarean because there was a rumor that Caesar had been born that way. However, the historians figured out that Caesar's mom was alive, so so much for that. But the name stuck, so we still call it a cesarean. Now, the history of the birthing process is really interesting, and I don't expect you to memorize all this. I'm not going to ask you history questions about the birthing process, but it's interesting to see how we got where we are now, because there's been an interesting sort of arc in the way babies are born. Baby having wasn't a medical issue for the longest time, and early, going back historically, babies were born at home, and with the help from women in the community, some of which were called midwives, but they were just women that had babies, and they would go over and help each other. And it wasn't considered a medical process, so the infant mortality rate was pretty high, as was the maternal mortality rate. There's history where women often really, really young in their first pregnancy, would have serious bouts of anxiety because they had seen so many women die in childbirth. So in some of them, they felt like being pregnant was just a death sentence. Now, they didn't have birth control or control over getting pregnant. So it was kind of a really difficult thing for some females. And there was a fairly high risk that compared to now, that they would die in childbirth. But then with industrialization came a rise in formal medicine, which started with the physicians making rounds basically by carriage home to home to take care of people who needed a physician. And they didn't have hospitals in most of the rural areas. And actually hospitals were started as rooms in the upstairs of the physician's home. And that's how they first began to take care of people in any kind of a medical setting. But for baby delivery, the physician would just show up at the house and help the mom deliver the baby. And then with industrialization continued through the Industrial Revolution, the formation of hospitals and technical medicine, advances were made in medicine. You got anesthesia and antiseptia and a more understanding about microbes and then the invention of antibiotics, and it all peaked out to where at that point women were sort of sidelined on the whole birthing process. And the typical delivery in the 1950s, by the 1950s and 1960s, was a woman would be pregnant, be monitored by a physician. At some point, when she went into labor, she would go to the hospital. And when she went to the hospital, it was more like a surgical procedure. So the husband would be in, or the family would be in the waiting room, and the mom would be taken back and put in a labor room. She would labor away in the labor room. They would monitor her, and then when she was ready to deliver, they would move her to the delivery room, which would look like a surgical room. And it had a surgical table with stirrups. They would put her on the table, put her under anesthesia, shave her mons pubis, bathe the area in betadine and antiseptic, and they would actually deliver the baby in a sterile field. And that was done for quite a few years. But the anesthesia turned out to be kind of a problem because it would suppress contractions, and that increased the necessity for forceps deliveries and cesareans. And so with the women's movement in the 60s, and a French obstetrician named Lamaze had developed a natural childbirth technique in France and was training his patients in the delivery process and introducing them to it through a kind of a training program. And then he had a natural childbirth process where either a mom or sister or husband would come in and actually serve as a coach and help with the process. And then the next thing was the hospitals would adapt by realizing that they didn't need to be in a sterile field, and they created the birthing room and put surgical lighting in the ceiling, and they have what we have now, which is a birthing room in the hospital. And it's got a little place for the coach to sleep, and fetal monitoring and vital signs monitoring and an anesthesia cart and all the things that you need in the room in case there's a problem, and you don't have to go to the delivery room unless you're going to do a cesarean, which they just take them to surgery for that. So they can do the baby delivery right in the birthing room. And that turned out the whole prepared childbirth became the standard now. So every female that goes to an obstetrician gets referred for natural childbirth classes and introduced to the process before they actually go into it. Anesthesia now is mostly localized in the form of what's called a spinal saddle block or epidural, where they put localized anesthesia in the spinal column, and just to sort of numb the pelvic floor so the pain's controllable. They don't use general as much as they used to, although they still use some general analgesia, but they don't use general anesthetic unless they're going to do a cesarean. So that's quite an advance, driven mainly by the women's movement and the women's liberation movement, who had threatened to kind of bail on the hospitals because they started using midwives and having babies at home again in the 60s. And there were cases where women were showing up at the hospital without any medical history, in distress with a baby stuck in the birth canal, and the hospital hadn't been informed and they weren't getting medical care, and so that wasn't ideal in some cases either. So everyone's kind of adapted to a much better process. What's finally happened too is the credentialing of obstetrical nurse practitioners, which can actually deliver babies in the hospital without being completely dependent on physicians. And that's improved the whole access to services for women having babies in a much more comfortable environment. And so it's a much more modern approach now.